holes, the simple ones, the more complicated ones, particularly by focusing on the myopic ones, and some other varieties, including the partial thickness. And I think Πάρης is going to probably go through that in his talk regarding the new international vitreomacular attraction study group classification with regards to the vitreomacular attraction syndromes or interface syndromes. But as far as the full-thickness macular holes are concerned, perhaps we should forget all about stages, and what really matters is size of the middle, the size of the base, as well as whether there is any traction around the edges of the hole. And of course, the pathogenesis is still not entirely clear, but we're talking about different kind of tractional forces, anteroposterior traction after incomplete PVD, and perhaps combined with an epiretinal traction, tangential traction by proliferation of membranes on the surface of the macula. And of course, Kisi and their colleagues published their own theory regarding the posterior precortical vitreous pocket, which is this nice pocket there, which is not abnormal. It actually exists in all of us from the various stages of our life. And they tried to combine that and perhaps declare their own theory with the three pathways. And what I would like to show you here is that basically the vitreomacular traction syndrome and the macular hole perhaps share the same pathway of pathogenesis. But anyway, after this short introduction, let's move on to our first case. This is a 65-year-old woman with a vague symptomatology of reduction of vision in both eyes. And she had that sudden drop of vision in the left eye with a vision of 310 and metamorphopsia, and a vision of 810 plus on the right eye. And as you can see here, I mean, Louisa, maybe your comments on that? It's obvious, isn't it? It's a full-thickness hole in the left, and a vitreomacular traction in the right eye with a foveal detachment and some cysts. So I would like to just raise the first question, the first MCQ, please. How would you manage this patient? Watch both eyes for spontaneous resolution, operate in the left eye and watch the right eye, operate the left eye and perhaps use Zetria, enzymatic vitreolysis for the right eye, Zetria for both, or operate both. Please vote. And the results, please. So basically, people have voted for number 2, operate the left eye, watch the right eye, but there is a 25% who believe the opposite, well, the other option. And I think that's the correct answer because, the slides, please. We got enough evidence to suggest that if we just watch the vitreomacular traction, it will perhaps spontaneously resolve. And the reason to operate on that or do anything about it is a definite visual or anatomical deterioration, whereas there is enough evidence to suggest that the full-thickness macular holes do very well by operating. I didn't mention anything about Zetria in the left eye, but we'll come into that in a minute. So our decision was to operate in this eye. Of course, there are certain debatable issues as to whether we should be removing ILMs or the type of tamponade needed, long-lasting, short-lasting gas, oil, etc., or perhaps should we posture or not? And if we've got the time, we can discuss about all this. It's a worldwide discussion, of course. But what we chose to do, what I usually do in my normal cases, I do a vitrectomy, ILM peel in all of my cases, regardless of stage, SF6, and I ask them to posture for at least 5 days, 5 to 7 days. I'm a bit conservative. So by doing that, we managed to close the left hole, as you can see here, but there is some fluid remaining. That's 1 month postoperatively. And of course, nothing has changed in the right eye. And that's 2 months. The fluid is still there, and the right eye is still 810. But things are improving in terms of symptoms. But 1 month after that, we decided to wait, of course. The patient comes and she's now got sudden deterioration of the vision in the right eye. And as you can see, there is a hole in the right eye now. And here, there's still some fluid there, and the vision stable at 510, improved from the first stage. So the next question is what to do now? How would you manage this patient now? So would we operate the right eye and perhaps use a steroid in the left eye to allow or help the fluid to go from the operated eye. Operate the right eye and watch the left eye. Use Jetrea in the right eye and watch the left eye. Just wait for both eyes, or perhaps do something in combination, or just vote. And the results, please. Well, it appears that my correct answer is 2 and 3. So we can either use an operation or use a Jetrea. Remember, the question is whether it is correct or not. So, Luisa, can I have your views on that, about Jetrea? Do you use Jetrea anymore?
I'm afraid I must admit I don't use Jetrea anymore. I had very variable results when I used it that didn't really match the study results. And so for me, as you mentioned before in the previous thing, I think for me surgical results give such predictable outcomes. And in the UK, where we have to think about the cost of treatments, an injection of Jetrea is the same as a vitrectomy, but the results or the outcomes are much lower with Jetrea than they are with an operation. So I would use an operation in this case.
Yeah, I quite agree. No worry, I wouldn't use it either. But as I put it here, remember, these are the results of Jetrea. They are very poor. Thanos will come to you in a minute. They are much more inferior. But the reason why I put it there is still an approved treatment. Absolutely. So as I put it, it was a bit tricky. Is it correct? Well, it's not entirely incorrect, but I would use a vitrectomy. So we quite agree on that. Perhaps there is another option. Just put air in the cavity. We call it pneumatic vitreolysis. And there is some growing evidence showing that this may also help to release the traction, at least the vitreomacular traction. And perhaps this is a promising future. We need more evidence on that. But anyways, the decision was to operate on the right eye now, who's got a new macular hole, and of course wait for the fluid in the left eye to resolve, because that's what they usually do. And we plan the patient for operation, and the patient comes on the day of the operation and says, oh, listen, doctor, the vision has improved. It's now measure 5/10. And as you can see here, there is still some traction, but it appears that the hole wants to close, basically. It's partially closed. So what would you do on that, Luisa? Would you wait or?
I would wait. I'm smiling at this because I had a patient literally 2 months ago with exactly the same story who presented with this.
Did you operate or?
Well, what we did was we booked her operation for, we said, okay, well, let's book the operation for 3 weeks' time. We'll redo the OCT scan when you arrive. And depending on what it shows, we'll decide to go ahead or not.
So you rebooked for another operation, but that's on the same day of the surgery.
Yes, I would have postponed the surgery on that day and given her another go. That's what I did.
I mean, it's a bit. It's not logical to go ahead with the patient telling us that it's getting better. There is a hope that it may resolve on its own. Exactly. But of course, the patient comes back a month after that, almost a month, and the vision is down to 10. The hole is open again, and then we decided to operate. And interestingly, if you look at the other eye, there's no more fluid, and it's up to 7/10, so it has resolved. So we won here anyway. In fact, in this situation, we've been lucky we won in both eyes, because after the same vitrectomy kind of technique, the hole has closed, still fluid here on the right eye now, but after a year, we've got these results of 7/10 and 8/10 closed holes, and a nice microstructure environment on both eyes, which explains why we got these good visual results. And I wanted to stop and do that for a minute. There is enough evidence to suggest that we need to, as with other diseases, other vitreomacular traction diseases and other diseases, we can use as biomarkers the condition of the outer retinal layers, the ELM, the SOS, as a predictor of how the prognosis would be with the patients like that. Even after even if the holes close, we may not have such a good result unless we've got a nice result with the microstructure. So, okay, enough about simple holes. What about the more tricky ones? Let's say the chronic ones or the big ones or the myopic ones. Myopia is an ongoing problem, so I want to focus on that. And of course, with the myopia, we've got two different types of holes. The ones who look normal in a myopic eye, and the ones who look like that. And that's a schisis-related, foveoschisis-related hole. And of course, although we don't fully understand the pathogenesis, it's still forces, structural forces opposing to each other which cause this. But what you need to remember is that these holes can be related to retinal detachment coming out of this hole, from this hole. So basically, these holes are very notorious for not being able to close, and people who come up with many ideas. It's not just doing a vitrectomy and ILM peel. We need to perhaps use long-lasting gases or maybe even silicone oil. It's an ongoing conversation all around the world. But a new technique, fairly new technique, is the inverted ILM flap, which you can see here. We don't remove the flap of the ILM. You just put it inside the hole in layers, and you create a kind of scaffold along which glial tissue may just form and help the hole to close. But anyway, there are certain other techniques as plan C, D, E, if these fail, not to mention that the macular buckle, you put a buckle behind the macula, may sometimes do the trick, as with this case here. The case is gone. It's from the literature, but you can see the buckle. It's an old-type buckle. If everything fails, you can even try that, and there is evidence in the, well, not enough, but evidence in the literature which may show that this may work. But yes, the outcomes, if we're talking about simple holes, they're pretty close, the results, to the normal non-myopic holes, but the ones which are related to the schisis, well, the results are still not very good, although they have improved, but not as good as we like them to be. The retinal detachments which are related to those holes may be close up to 80%, but the visual recovery is a bit more complicated issue. It depends on things like chororetinal atrophy, which is, of course, the issue with the highly myopic eyes, or how the pigment epithelium works, and so on. So still not very excellent visual outcomes. But let's move on to the final group, which I would like to sort of discuss about, which are the ones who are not full-thickness macular holes, another vague subject. When I'm talking about, I'm referring to the lamellar holes or the pseudo-holes. And if you look at the International Vitreomacular Attraction Study Group classification and the old classifications, what we feel is that the pseudo-hole is basically an epiretinal which looks like a hole. Or the lamellar hole is a little gap, on the inner retina with a split in the middle retina and fairly normal photoreceptors. But of course, there are some cases like that where there is an epiretinal membrane, which shouldn't be the case on the lamellar, the traditional classification, but it does look like a lamellar hole. So what is that? Is a pseudo hole or a lamellar hole? And what is this? And this is a case on the same macula from the same patient with different sections. It looks like a pseudo hole here and like a lamellar hole here. So perhaps what we should do with these holes here, a proposal, which is not entirely evidence-based, but it is a proposal, is to forget about pseudo holes and discuss about only lamellar holes. So just use this terminology, because most of them come with an epiretinal membrane or with another kind of epiretinal proliferative material, which is called lamellar hole epiretinal proliferation. You can see it here. We don't know what that is, but it's not exactly an epiretinal membrane. But what we know, it may be linked to Miller cells or allocytes. And we also know that, or there is evidence to suggest that these, if we operate on that, they don't do very well in terms of visual rehabilitation. But all these cases may potentially be surgical cases, whereas some other kinds of lamellar hole will come out of a rupture of a cyst on chronic edemas, say after a cystoid macular edema, diabetic edema, or a McTell case. These have got a very poor prognosis, and they are not surgical cases. So having said that, let's go through another patient, and that's my last patient, 76-year-old woman with a mild gradual decline on the left eye, and she's pseudophakic on the right eye, and she's got this mild epiretinal membrane here. And she's got a cataract, a mild cataract in the left eye with this appearance. It's a lamellar hole. 810 in the left, 910 in the right. So, Luisa, any comments on what we should do on that patient here? What would you do anyway?
I must admit, I'm still not entirely convinced about the outcomes of surgery in these patients, and so I'm still sitting on the fence with these now. I think her vision is still very good. I would be more inclined to observe and see how she goes than to intervene too early.
Alex?
Yes, well, I'm either going to do nothing, which means I'm just going to observe because the vision is relatively good. I'm not sure what her symptoms are. The problem is, what is going to be our decision if we're going to do cataract surgery? I mean, what's the role of the cataract surgery, and whether are we obliged to do something with that just because she's going to have cataract surgery?
She's 8-10 now, and she was asked to come back in 6 months. She's coming back in 18 months. Yeah. And she's now 310.
So that's usually the issue, that people come back with worse cataract, not necessarily bad structural OCT, the vision is down, and then you need to do something for the cataract, of course, and then that's the question to us.
She's got a dense cataract.
What's going to happen? And the whole question is, what do we know? How will the cataract, an eventual cataract surgery, is there an increased risk of, let's say, cystoid macular edema and refractory cystoid macular edema in these type of cases? I believe, I mean, I have really no evidence.
What would you do here?
That because I'm going to do the cataract surgery, I'm going to take care of the membrane too, if I believe that there's a tractional mechanism to the membrane.
Well, that's my question. Can you vote on that, please? Do a cataract removal, do a vitrectomy, do a phaco-vitrectomy, watch. Maybe 2 or 3 are both correct. Please vote. And can we see the results, please? So you do a phaco-vitrectomy, Alex, or a vitrectomy combined?
Myself, yes.
Okay, I decided to do the cataract, and I would agree with the answer of 83%. And can you have the slides back, please? And she's now 2 months post-phaco, and she's back to 8-10 with the same picture. Yeah. And this comes to the evidence which says that most of them do not, I mean, the visual acuity is good and the symptoms are minimal related to the lamellar hole, and the natural history is pretty good. And so basically the last question I'm going to be finishing with that is, when would you operate? And this question is actually trying to answer that, and that's in my summary in the next slide. So basically the following statements regarding lamellar holes and pseudoholes are true. Pseudoholes should be managed as epiretinal membranes. 2, lamellar and full thickness macular holes are exactly of the same variety, or one variety, and should be operated immediately. Lamellar holes, which are associated with certain types of epiretinal membranes, may occasionally benefit from surgery. The decision to operate on lamellar holes should never be based on functional visual criteria. 1 and 3 are correct, 1, 3, and 4 are incorrect. Please vote. And the results, please. One and 3 are correct, I think, is the correct answer. And I think if you just go back to the slides, my last slide. This basically summarizes that most remain stable, remember. They are associated with membranes, and the ones with the epiretinal proliferation do much worse. But the minimal evidence in the literature, and of course the experience, supports that we should only decide to operate if we have a definite visual deterioration or symptoms-related deterioration. So in these particular patients, or some of these patients, the surgery may offer benefit, but it's very unlikely to happen. So that's basically the take-home message on those cases. So in conclusion, the simple macular holes do very well with the modern technology. The tricky ones do better than previously, but not as good as we would like them to be, and there are different techniques we have invented. And the lamellar holes usually do not require surgery, and we need to be careful with those. Thank you very much.
Right. Thank you very much. That's excellent. Thank you. So finally, we have Πάρης Τρανός, who's going to tell us about epiretinal membranes and pose some more questions to you.